the clock?
Yeah.
We'll do it to the clock. Okay. Okay, so we are recording, just so that everyone's aware of that. And now I'm going to go back and do share screen. Okay, there we go. Can everyone see? Okay. So we're going to talk today about fibromyalgia, and we're going to talk about what it is and how to manage it. I'm the director of chronic pain at Rehab Specialists, and I hope you guys get a lot out of this, and this is able to help you. What is fibromyalgia? It's a disorder. It's characterized by like just kind of pain everywhere, pain throughout the whole body. There's other symptoms that everyone's nodding their head like, yeah. Multiple different locations, tender points, tenderness with touch and palpation. You can also have like fogginess with your brain, sleep disturbances, and other symptoms that don't always make sense. So if you're having weird symptoms that people are like, what is this? That's totally normal for you to be having those things with fibromyalgia. We don't know what causes it. We're not really sure. We talk about the nerves being oversensitive, but we're not sure why they're oversensitive. But there are some things that we can do for treatment. You may also have mood or memory issues. And it can be brought on by like stressors, either a physical stressor like a surgery or an emotional stressor. And it can be made worse by those things or worse by getting sick. So any of those things can upregulate it or downregulate it a little bit. Understanding your pain can help you get your life back. So knowledge is power. Understanding that the nerves are sensitized, understanding that when you have pain, it doesn't mean that you're damaging your body. We need to keep it in check, and we'll go kind of into how to do that in a little bit, but understanding that it doesn't mean you're damaging your joints, it doesn't mean that you're harming yourself, but it can be uncomfortable, and there are kind of appropriate ways to challenge that, and there's inappropriate ways to challenge that. Doing activities that are uncomfortable to small amounts can be helpful. And this is known as graded exposure in small doses, though. Not just going overboard and doing too much and then being disabled the next day. That's called boom bust. So there's 5 kind of big psychological factors that go along with any kind of chronic pain condition. These are normal occurrences with any chronic pain condition, chronic low back pain, CRPS.
Okay, I'm going to give you the ID number.
Fibromyalgia.
I just lost it. Okay, so write down this ID number.
Me? Oh.
It's 869.
Hi, Jim. I think you'd have to mute her.
It's a Zoom number. It's a Zoom ID.
Okay.
Okay.
69. Is this for the
869.
I think she's talking to someone else.
I think she's
You
talking
can
to
just
me.
click on her.
93782.
869-937.
93782.
82. Okay. Okay. I think that's to access it later.
To her and she told me that it was there is no password.
Okay.
Hey, Jim, you probably want to put her on mute.
I know, I am.
Okay.
Okay. So we're going to talk about these psychological factors here. The first one is fear. Fear has to do with kind of fear of the present. This is a present time thing. This is happening, and what does that mean? So when you're experiencing pain, what does that mean to you? What does that mean is happening in your body? Is this something we should be avoiding? Is this something that's damaging us? Those are all fear-related kind of beliefs. Catastrophizing. Catastrophizing has to do with like future thought. So I'm having pain right now. I'm going to be horrible later. I'm destroying my joints. This is going to get worse in the future. That's catastrophizing. So it has to do with future thought. Depression. This could be underlying depression, meaning you could have depressive episodes beforehand, or this could be depression in relation to your pain. So this may not have to do with the other layers of your life. This may have to do just kind of with your pain and your condition. You know, I can't lead a normal life. My life is really challenging right now. You know, kind of being down on yourself about your condition is really what we're talking about depression. You could also have underlying, you know, depression before fibro as well. Self-efficacy, we're going to get into this a little bit more in a minute, but this has to do with your kind of perseverance over your condition. And passive coping. Passive coping has to do with like you taking passive modes to help yourself out. We're going to talk about low self-efficacy a little bit more. We're going to talk about passive coping a little bit more. The important thing to realize is that these are all normal reactions to chronic pain. I broke my ankle about 2 years ago. I think I went through about all of these stages. So don't feel bad for feeling these ways. They're just not helpful. And they're just things that we have to work on. But they are normal to go through when we're in a stressful situation like this. Another thing is suffering equals resistance times pain. So this is kind of out of acceptance commitment therapy. And what it has to do with is we can't change where we are right now. We can tend to do things in the moment that will, we can do things in the moment that will make our future better. But right this second, we can't change where we are, and wishing we were somewhere else or wishing things were different isn't helpful because it creates more suffering. So trying to just be okay with where we are right now, that's a hard pill to swallow. This isn't easy. So we're gonna get into some of the fear. We're gonna talk about the fear a little bit. So this is just an example, but you know, I have a lot of patients that you may have. A lot of people with fibromyalgia have kind of co-occurring conditions. You may have MRIs of your low back, for instance. What this shows is that pain in the low back actually peaks about 45, and then it starts to get better. As our discs dry up, maybe as our pain receptors get a little more insensate, people actually don't have as much back pain. And I know that you know people that are older that have back pain, but we see a lot of people that have like acute disc herniations kind of at the top of this bell-shaped curve. If we look at the MRI, of course, or the X-ray, we're going to see more arthritic changes. We're going to see more degenerative changes on the imaging. But these don't correlate with symptoms getting worse over time. So don't think as you get older that you're going to get worse. Some conditions do, some conditions don't. But there's a lot that we can do to help out with this. Stress response. So when we're afraid, when we're scared, we go into the sympathetic nervous system. This is the fight or flight system. I'm not going to go into all of the things that I have listed here. I'm just going to talk about why this is important. This isn't a sustainable system. This system is designed with, there's a tiger and we're running away from the tiger, and then we get away from the tiger and then the stress goes away. This isn't designed for taxes. This isn't designed for you know, like stress issues with relationships that go on and on and on. This system is designed to be activated. Then we're supposed to get out of this system. When this goes on for a long period of time, it's kind of maladaptive. So finding ways to relax and turn down this system is really, really, really helpful to bring the body back into balance, hormonally and stuff like that. And it also increases muscle tone. It increases heart rate, difficulty with sleep, increases depression, lots of side effects of this system being activated all the time. So your brain produces a lot of natural painkillers. It produces some of the strongest painkillers in the world. You hear about people and their legs get blown off and they don't even know, until they look down and they're able to get out of that situation. Those painkillers and that ability to shut off pain is much stronger in the brain. I mean, we don't have access to this completely. We can't just be like, okay, turn on your natural painkillers, but we do have some control over it. What we found out is that those natural opioids that get released in the brain, when we're afraid and when we don't know what's going on, those get shut off. So that's the dry brain over here, the one with this spigot only dripping a little bit. You're not releasing all those natural opioids into the brain. So knowledge is power. Understanding you're not causing damage, understanding that this pain doesn't mean you're not going to necessarily get worse in the future. Getting some control over this is helpful at turning those on. Does that mean it's going to go away? No, it's more like it turns down the volume knob or turns up the volume knob. Your brain decides if it'll be in pain. Again, we're just going over what goes on kind of at a nerve level. So at this nerve level, let's see if I can change my pointer. Yeah, there we go. Okay, so at the nerve level, we have a nerve. In the case of fibromyalgia, this may just be a sensitized nerve that's firing without any stimulus at all. It goes to the spinal cord. It goes to the spinal cord and then it goes up to the brain. The brain, before it produces pain, it kind of takes a look around at what's going on in the world and kind of your mood and what's going on in the world and your world. And it says, is this dangerous? So one of my favorite stories is a famous pain researcher from Australia. He got bit by a snake in the woods, walking through the woods one night, and he didn't think anything of it. His brain decided, oh well, this is one where it was maladaptive. It decided, oh well, you've been through the woods, you get scratched by sticks. This is normal. There's nothing to be concerned about. And he ended up in the hospital for like 2 weeks after this. A couple months later, hiking in the woods again, gets scratched by a stick. Horrible agony. And, he's like, oh my God, I think I've been bitten by a snake again. And, the brain says, danger, danger, danger. And it amps up this pain signal. And he looks down and sure enough, he'd been scratched by a stick. So our kind of our set and setting and our understanding and our beliefs about pain can turn that volume up on the pain, or it can turn it down a little bit. So, the moral of the story with this part of this is no pain, no brain, no pain. The pain is the output of the brain. It's not the input of the brain. We're going to talk about pain behaviors a little bit, kind of the maladaptive ones. And these are definitely related to the psychological, but these are definitely related to what we were talking about before with fear and acceptance. So I would say that the avoiders, this is a fear-based approach. So what they do is and sometimes we go back and forth between these approaches. We'll talk about that in a little bit. We do some activity, we notice discomfort or pain with it, and we completely avoid it. And we just back off completely. Then, we might get a little brave. We notice pain again, back off completely. And this happens again and again and again. One of the underlying beliefs is if it hurts, I'm doing damage. And this is a fear of pain. So that's one maladaptive kind of behavior. The other is this boom bust. This is kind of not accepting. This has a lot to do with not accepting where we are right now and what we can change. So this has a lot to do with I'm going to push through this and I'm going to persevere. It doesn't matter how much I suffer later. I'm going to push through this and persevere. We know when this is occurring because this is the times when people are like, I'll give you an example. I had someone that they would clean their house Monday, and I asked them, why do you clean your house Monday? Well, they said, well, I clean my house Monday because then the rest of the week I rest for 2 days afterwards. I'm just bedridden after that. And I'm like, well, that's not really adaptive. You can't get stronger with that. And you have these long periods of disabilities. And then the brain says, and the nervous system says, I need to make the system more sensitive. And then we do it again. And slowly over time, when we have these pain behaviors, this leads to less ability. This line right here is kind of where pain comes on. And the pain comes on at lower and lower levels of activity. We're going to get into the adaptive way to deal with that in just a minute. Self-efficacy. So self-efficacy, what we're really talking about here is high versus low self-efficacy. So low self-efficacy is it's giving up on things a little too quickly. It's when we encounter an obstacle, we just feel overwhelmed, and this is hard. So there's no judgment here. We're bringing this to your awareness. This isn't easy when we have an obstacle to persevere. Having low self-efficacy is tied to higher levels of disability in the long run. So having higher self-efficacy is tied to beating our symptoms. It's a long journey to get better, and it's going to take some time. So passive versus active coping. Again, this is research-based. Active coping, having more active coping tools is tied to beating your symptoms and having lower levels of disability. Some of these things like self-efficacy, active coping, fear, they are bigger predictors of who's going to be disabled than like MRI scans are. That research comes from low back pain, but the bigger predictors are the psychometrics, the psychological tests that we use to measure these things. They're much more important, we find, than the actual image of the back. And this is true with fibro as well. So active coping, actively engaging in things to make you feel better. Passive coping, waiting for something outside yourself to control your pain. We want to do mostly active coping, but occasionally we need some passive coping too. We just want to do as many of the active things as possible. So sometimes, we'll need to use heat, ice, or massage. We'll need to use pain medication. We'll need injections. But we don't want to primarily rely on these things. We want to rely on these things and use these things as needed. This creates more internal sense of control over the symptoms. So, some of the things that I have on here are meditating versus zoning out and watching TV. So meditating is an active process. Zoning out and watching TV is kind of a passive distraction process. Engaging in social interactions with people versus heat, ice, and massage. Again, these things can be kind of adjunctive, but they shouldn't be your main focus. That's what the research is showing. Exercise versus just relying on pain medication. You may need this occasionally, but this is where we need to be working. Doing your home exercise program, injections, getting psychotherapy, numbing out, psychologically with alcohol or weed. Again, CBD, stuff like that, it can be helpful, but we don't want this to be our primary method of feeling better. Laying in bed, doing charity work. And I put charity work because that helps us psychologically feel better. Cooking a healthy meal, eating, versus eating sugary or fast food to cope with stress. Aerobic exercise. So this one was really interesting. I looked at some of the research because I wanted to look at the research, and I needed to look specifically for fibromyalgia. The interesting thing that I found was that there's a high dropout rate when they did these exercise studies. This is because it hurts and because there's fear of hurting yourself. So when we looked at the control group versus the exercise group, about twice as many people in the exercise group dropped out. And they said, it's painful and I'm going to hurt myself. What they found was, though, that the people that persevered with those exercise programs over time did better. So you may do a little bit of exercise, be in some discomfort. I don't want you to push into severe pain and go into that boom bust cycle, but push into a little discomfort. Stay there. Let your body get used to it. After about 8 to 12 weeks, your symptoms are going to get better, but it's going to take time. As far as exercise prescription goes, 60% to 80% of your heart rate max, 10 to 30 minutes, depending on the study, 3 times a week. So this is, to calculate this, you multiply 6.8, 0.68, I mean 0.6, sorry, and then, or 0.8, that's your range, times 220 minus your age. That'll give you that heart rate value. So we need to get your heart rate up a little bit in order for this to work. It can't be, we have to get maybe a little bit of heavy breathing. Not a lot, but just a little bit of it. Adding resistance training along with aerobic exercise further decrease symptoms and increase function. Graded exposure. So now we're going to talk, I like calling this the middle path. If you guys know anything about Buddhism, there's the story about being two ends of things. So one's being like gluttonous and being kind of overindulging, and then the other end just completely avoiding, any sensual pleasures at all. So, that's where that middle path comes from, and that idea of that. So instead of the fear avoidant approach, we go into it a little bit, and then we stay there. And we just hang out there for a little bit until our body gets used to it. We don't want to go to the level where we're going to be disabled the next day. We also don't want to avoid discomfort completely. So we push into a little bit of discomfort. We hang out there. We try to do this amount of activity like every single day, a couple times a week. So we don't have these big fluctuations in activity where we're going up and down. We hang out there. When that feels like, oh, okay, that's no longer painful, we up it a little bit more into just a little bit of discomfort. So this is graded exposure. And then we hang out there. This is not, I did physical therapy and then I was sore for 3 days. This is more like I did physical therapy and I was sore for like a day. And then, but it didn't stop me from getting out of bed. It didn't stop me from doing things. So some of the sore but safe, pain's not a problem, and eventually over time, what we're gonna find out is that we're able to do more before our pain comes on. This talks a little bit about challenging DIMS and SIMS. So challenging beliefs or things in your life that create fear and create kind of a sense of danger in your life, and adding more things in your life that create a sense of safety. Lifestyle factors. Eating processed foods, red meat, alcohol, and sugar, that all increases inflammation. Red meat, the saturated fats, can be problematic. And, we can do these things in small amounts, but this just can't be a lot of your diet. Processed foods, they contain a lot of omega-6 fatty acids versus omega-3 fatty acids. So our diet in the past had a lot of like this, omega-3 is like fish oil. That's what they sell it as, but it had more of that kind of fat in it. And it had less of like corn oil. As because of our agriculture, because of, other societal things like farm subsidies and stuff like that, a lot of processed food has a lot of this omega-3, omega-6. Eating fried foods. All this stuff has been shown to increase depressive symptoms, increase pain, and cause general health issues. And it's the amount of it. Occasionally having some of this stuff's okay. You can look into having a anti-inflammatory, into more about this with an anti-inflammatory diet. There's a lot of stuff online with that. Sedentary lifestyle, sleep disturbances, and stress are other lifestyle factors. We'll get into those more. Sleep hygiene. Sleep's important. Sleep's really, really important, and it's hard for people with fibromyalgia. This is a common complaint. I have trouble getting asleep. I have trouble staying asleep. There's been something, we know that if you sleep for less than 6.5 hours, it decreases serotonin, it increases depression, and it increases pain. There are some things we can do to help with that. And if these things don't help, then you can talk to your doctor, and there's medications and stuff like that. But there's some kind of standard things that we can start to do to get us on a more regular schedule. Stop using electronics 2 hours before bed. If you have to use electronics, then you can put on blue blocking lenses. This helps with melatonin. Melatonin is our sleep hormone. So that helps us get to bed. We also want to train our brain that our bed is only for sleep. So the bed is only for sleep or sex. Reading in bed, doing stuff like that can be detrimental to your sleep-wake cycle. You're much better off to read outside of bed, under some dim lighting, and without a backlit screen. And then before bed, then only go to bed right when you're ready to sleep. If you can't sleep, get up and get out of bed. The reasoning for this is that we train our brains, if we can't sleep, that it's okay to stay awake in bed. And so we want our brain to be used to, I'm in bed, I'm asleep. Going to bed at the same time every night and getting up at the same time every day. So even if you can't sleep, it's good to get up first at that same time every morning. This again helps train our brain to get into that circadian rhythm. And then when you do get up in the morning, expose yourself to bright light early in the morning. So, the easiest way to do this is if it's normal, if you're waking up at like 7 or 8 o'clock, to get outside and get some sunlight. If you're not, you can retrain the circadian rhythm with something like a light box. And then making sure it's dark at night too. No caffeine or alcohol in the afternoons. These are all important things. These will all help you sleep better. And I don't think it's on here, but having a sleep routine every night when you go to bed can be really helpful. So what do you do before bed? Do you drink a cup of tea? Do you, you brush your teeth, right? Do you drink a cup of tea, read, and then brush your teeth? Having that ritual is really, really helpful at training our brains that this is the time to go to bed. Stress and depression. These co-occur with fibromyalgia. They also can intensify it. And we can be depressed or stressed because of the fibromyalgia. So, this is circular in nature. It's which came first, the chicken or the egg kind of situation. Meditation is really helpful. If I know some people don't like that, but so I've listed other things too. Maintaining an active social life. So, getting out and seeing people. This is hard right now with COVID. I was thinking about general things, but this is hard right now. But get on those Zoom calls and make sure you're checking in with people. We're all a little more socially isolated right now, so it's important to keep those social interactions going. Seeking help from counselors or therapists, or like a psychotherapist. So for some of the pain psychology things, the things that have been found most helpful for treating chronic pain conditions are acceptance commitment therapy, which has to do with just kind of accepting the here and now and then setting goals for the future. Cognitive behavioral therapy to change some of the beliefs around your pain. In motivational interviewing. Motivational interviewing is being used a lot by physical therapists. And one thing that's not on here is pain neuroscience education, which is a form of cognitive behavioral therapy that's being used by physical therapists. It's important to get outside and get some sunlight, get out into the green space. Again, this is hard right now, but this has really been found to be helpful for mood, is getting out and finding in nature. Having a spiritual religious practice and a healthy diet. Again, that comes up with stress and depression, managing that. Helping others has really helps people improve their mood. So what we have here is we have, this is called MAPS. This is something else that I thought was interesting. Doing both meditation and physical exercise is very, very, very helpful at decreasing depressive symptoms, even in individuals that aren't diagnosed with depression. So in this study, what they did is they took a depressed group and they did this program with them, and they took a group of people that didn't qualify as depressed, didn't have that as a diagnosis, even after taking a depression index. And they found a 40% reduction in depression symptoms over 8 weeks. I mean, that's huge. That's absolutely huge. And it only took 2 hours a day. I mean, sorry, 2 hours a week. 2 hours a week to do this, and they found 40% reduction in depressive symptoms. That's similar to the depression reduction that we get with like an SSRI or a medication for depression. 40% is huge. What they did is they did 20 minutes of meditation, followed by 10 minutes of walking meditation, followed by 30 minutes of aerobic exercise. And huge, huge, huge changes. I think that's it. So I will, let's see. You guys can unmute yourselves and we can talk a little bit. And admit, and then stop share. And let's see. Do we want to, so we're unmuting. Do we want to record this part or do we want to not record this part?
Yeah, let's not record this part.
Let's not record this part.
Yeah.
So that we get a little bit of privacy. If anyone, okay.